Somebody needs to watch you do the thing and say that you can do the thing based on watching you do the thing before you do the thing on your own. And then every year they have to watch you do the thing again to make sure that you could do the thing. And the person watching you and saying you could do the thing needs to also know how to do the thing. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we are going to be covering competencies. But first, if you like our content, please like, share, and subscribe. So what is a competency? A competency evaluation is a type of evaluation that all agency clinicians need to undergo prior to treating patients. Competency evaluations are done from one clinician to another within the same discipline. So pretty much nursing does nursing, PT does PT, therapy like OT does OT, and so on. So you can only be competencied by somebody within your discipline. The only exception to that, which is like the forever exception, can you guess? It's home health aides. Because home health aides don't competency home health aides, you need an RN to competency a home health aide. That brings us to the next kind of idea of who can competency, and it's an evaluation level staff needs to competency other staff. So a physical therapy assistant can't competency another physical therapy assistant. You need to have an RN or a PT or an ST, blah, 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 like that, competencing their assistant level counterpart. And if you are from the evaluation level disciplines, an RN can competency another RN and so on, but an LVN cannot competency an RN, right? So really it's whoever can do the OASIS can do the competency pretty much. The evaluation level clinician needs to perform the competency on whoever it is within their discipline. And of course with CHHA, it's still the evaluation level clinician, but they don't have an eval level CHHA, right? So it's going to be the RN pretty much. So what is a competency? It's a skills evaluation list in which the eval level clinician, so let's call it an RN to an LVN or an RN to an RN, performs on another clinician during or prior to their first visit with a patient ever for an agency. So pretty much at hire. So during hire, you want to competency that clinician on their first visit or before their first visit. So what does that mean, on or before? So typically, essentially with the competency, the idea is that a clinician cannot perform a clinical skill for you that hasn't been already checked, like if they can do that skill or not properly through a competency process. So if you're onboarding a new clinician and now they have a patient, you can send the competency evaluation level clinician to the first visit with that person, and now they are supervising and watching how this person performs that skill, and then they're checking it off on the checklist as they see them perform the skill. Once that person performs all the skills that are ordered in the care plan for this patient, so like for example, they can't perform skills that are not part of the care plan if we're doing it on a kind of first visit thing. If they now have to go see a second patient in which they have to do things that have not been competency previously, you're again sending somebody to evaluate their ability on that thing. So competencies can be performed in a number of ways. There are like different kind of like methods for competency. The main one is observation. This is when one clinician observes the other one doing it and checks off that they can perform that skill. There's also like testing. There's like different kind of like verbal tests, things like that, where let's say a clinician describes how they would do it and you're saying is yes, they know how to do it or they don't. There's also a competency self-assessment, meaning they just go, yes, I know how to do this. I don't know how to do this. I do know how to do this. Certain items in the competency, like certain skills, require observation only. There are some things that are okay with other methods, but some things that absolutely require that the skill is actually observed as it is performed and checked off by another clinician. So this list of what's required to be actually observed versus can be done in other ways. It's a big list. We're not going to mention it today. We could have a listing of just some examples in the article, but we're not going to just go through the list because it's like by discipline, there are certain things and whatever. It's like a long list. But the point is, anybody you hire cannot perform any service that hasn't already been evaluated by somebody in your agency who's qualified to evaluate them and checked off that they are proficient in the skill. And so the requirements for competency are that at hire, prior to or during the first visit, you have the competency, and then annually thereafter. So every year you are performing the competency evaluation on any skills that that person needs to perform, essentially. So when we say annually thereafter, what do we mean by that? That means to the day 1 year or before. It can't be a year and a day. It can be to the day and before. Now, what happens if it is a year to the day? Well, that's non-compliant. But if you, like, let's say that person didn't have any patients, like they had patients for like 3-4 months in your company, and now the next time is like a year and a half later. Well, pretty much they can't go out without being recompetencied again. That's essentially what we're saying. A year can't go by without having the competency of visits or whatever. So the next kind of question that comes up is, what do you mean on or before the first visit? Like, how do you competency somebody before the first visit via observation? So you can competency people through a simulation process in which, for example, I pretend to be a patient. So I just act as if I'm a patient. And now they are performing these skills on me, and somebody is observing them perform the skills on me. For this to count as an observation-based competency that is acceptable, you have to actually perform the skill on me and not simulate. So in the case of things like vital signs, this is easy. But if we're getting into like wound, okay, I need to have a wound for you to do it. You know what I'm saying? Or IV or whatever, or injection. They need to actually perform it. So there's certain things that are appropriate for a simulatory kind of experience in which, like, okay, I don't need to have high blood pressure for you to check my blood pressure, right? But there are some things that require the person that is receiving the skill, so the person that you are like treating essentially, to have that problem for you to do it. Like, yeah, you can maybe simulate a blood sugar check if I allow you to, right? Like I can allow you to prick my finger and do the blood sugar check. But unless I have diabetes, you can't inject me with diabetic medication. So there are certain things you can do for observation competencies through a kind of dummy, and there are certain dummy, I mean, not idiot, but simulation. And there are certain things that you can't do. So other ways to get around that situation is the person being competency can accompany the evaluatory staff member on their visit that they're performing for somebody, but jump into those little procedures, whenever it's appropriate. So it's still technically the person being competencied, it's their kind of first visit. Anyways, they're performing the first thing to your patient, but it's not their first like independent visit in this way. So long story short, like, we're using all these big words, evaluating clinician, whatever, the competency, da, da, da. The point is, somebody needs to watch you do the thing and say that you can do the thing based on watching you do the thing before you do the thing on your own. That's, long story short, it's that. And then every year they have to watch you do the thing again to make sure that you could do the thing. That's it. That's long and short of it. And the person watching you and saying you could do the thing needs to also know how to do the thing. So that means somebody has already competency them on the thing. And so it's this like big, long kind of chain. So what happens if you only have 2 clinicians in your company and they both need competencies? Well, they can competence each other, and that becomes a little circular reference. But anyways, it's allowed and it's acceptable. If this guy competencies this guy and then this guy competencies this guy, that kind of seems to work. So that's pretty much it for competencies. I mean, there's of course so many nuances about it. You have to, and things like that. But the general idea is whenever you're onboarding or hiring someone, somebody of their discipline needs to confirm that they can do the thing. And that's it. So again, my name is Mariam Treystman. This was a brief overview of like what is a competency evaluation in home health and hospice. And if you like our content, please like, share, and subscribe. Thanks so much.